Okay, let's talk about some special precautions or even contraindications, not for the patient, but for you, the therapist. You are in the water more than any of your patients. At the most, your patient might be in the water 45 minutes, 3 times a week. You are in the water 3 hours a day, 4 hours a day, 5 hours a day. And you're crazy if you think that that does not have the potential for hazards to you. In fact, they've come up with what they consider occupational hazards to being an aquatic therapist. Let's hit the highlights. Number 1, recreational water illnesses. These are all the things that are cropping up in spas and kiddie pools and public pools and lakes, and now even sometimes in therapy pools. So you have the mom whose child is wearing a normal diaper and poops in it, and instead of shutting the pool down, she not only dips the child in the water to wash their hiney, but dips the diaper in the water to wash the poop away. That's the kind of thing that you will see at some public pools. Even in a therapy pool, you have the potential for having bacteria or fungi or other infectious disease being transmitted. Yes, chlorine, bromine kill things, but they don't kill them instantly. It's not immediate. It might be 10 seconds, it might be 10 minutes. And so there is still the potential for infection, and you, as the person that is in the water more, has a greater potential for catching something. Well, what about the rash that you're not sure? Is it like a bacterial rash, or is it that I'm allergic to the chlorine or bromine in the water? The easy way to know is how long did it take to come on. If it's less than 24 hours, especially if it's just a few hours after immersion, and some people a few minutes after immersion, then it is a contact dermatitis. You are allergic to the chemicals that are in the water. Or not a frank allergy, but you are sensitive to them. Now, chlorine sensitivities don't go away. The more time that you spend in water, the more likely you are to have a sensitivity at a lower and lower and lower level of chlorine. So that is one of the major reasons why pools should consider putting in a supplemental system above and beyond chlorine or bromine. And a supplemental system is like an ozonator or ultraviolet light, because these allow you to drop down how much halogen or how much chlorine or bromine that you have in the pool, so that you are less likely to trigger a sensitivity. Now, there have been many of my colleagues who love the water, and they are not in the water today because they spent 5 hours a day, 6 hours a day, 7 hours a day, 8 hours a day, 3, 4, 5 days a week for years in the pool. And one day they woke up, and that day they went to the pool and they got a rash, and they never were able to get back in the pool and not have that rash. So you have to watch your skin. Your skin is a living organ, and you have many things that you can do to care for it. But the first rule of thumb is that you need to rinse off every time that you get out of the water. Don't let that water dry on your skin. You need to use lotion. You might choose to use something like the Kiefer swim screen that the Olympics teams use. It's a silicone-based rash guard that you put on, and it kind of prevents your skin from absorbing. But the first and highest rule of thumb is stop spending so much time in the pool. If your facility is making you be in the pool 30, 35, 40 hours a week, you probably need to have a talk with somebody. It's hard to find people willing to be in the pool, but it's going to be even harder to replace you when your skin can't take it anymore. Okay, your skin isn't the only thing that gets irritated by chlorine. Chlorination produces byproducts. It's the chemicals as they're breaking down. And when they break down, they produce these chlorine byproducts that you then inhale. And they have done studies that show that swimmers and non-swimmers, the people that are in the natatorium, like the lifeguards, are excreting these chemicals in their urine because you're taking it in and your body is metabolizing it. And they actually have found it in the blood and the breath of people that aren't even in the swimming pool. And the truth of the matter is that for about 18 inches above the surface of the pool, the air is pretty bad because those chemicals are off-gassing and they're heavier than air. And so they hover right there above the surface of the pool, which is why you need ventilation in your pool that blows those byproducts away and puts fresh air there. And if you tend to have a cough that comes every time that you show up at your pool, or you walk in the door and you smell this strong chlorine scent, or your eyes start to water, your ventilation is bad and you need to do something, because they are actually starting to say that this is a higher health risk than even like a recreational water illness. Dehydration. You are prone to it. Water diureses you. Immersion in water diureses you, and they've done studies that show that if you take someone who is incredibly thirsty and you put them in vertical in the pool, their thirst goes away. Let's think about it. Your body is pushing all this fluid up to the core. It's passing volume receptors. Those volume receptors are saying, we have too much volume. Ditch it. Get rid of it. In other words, go to the bathroom. And on top of it, they're telling your brain, do not signal thirst, because then they'll drink and then we'll have more volume to deal with. And so you can actually take someone who is truly thirsty, put them in the water, and they will lose their thirst. So certainly you have to drink when you work in the pool, whether you're thirsty or not, because you are not going to be thirsty. It's one of the #1 things that happen to people that work in the pool a lot. And kind of a simple test to know if you're dehydrated is an old runner's trick. And it's when you go to the bathroom before you flush, you turn around and you take a peek. And if you have a very dark urine, some people say the mellow yellow color, then you know that you're dehydrated and you need to drink whether you're thirsty or not. And you shouldn't chase your thirst. You should drink first. Lastly, burnout. If you're asking your employee to work in the pool 5 afternoons a week, they're rushing through their lunch because their 11:30 patient got there late, and so lunch didn't start till 12:15. They have to get to the pool early enough that they can put their bathing suit on and be there when their patient arrives. And lunch gets shorter and shorter, interaction gets shorter and shorter, and you're asking kind of a dual set of documentation, plus the fact that aquatic therapists cannot document when they're treating their patients. Now, you can do a point of service documentation at the beginning of the appointment, especially if it's a 45-minute appointment. But once you're in the pool, you can't. You just can't. We've thought of every way that you could do it. Waterproof paper, waterproof laptops. You really just can't do it. And so one of the best things you can do for therapists that work in the water is give them another half an hour for documentation, because they need it. You don't want your aquatic therapist to go away, because there's not, a lot of people that want to put a bathing suit on every day, especially when you live in Wisconsin or Minnesota and you emulate the Pillsbury Doughboy around about December. Take care of your employees. Okay, let's take a minute and just discuss some of what are called aquatic specialty techniques. Because the beauty of the pool is the fact that you don't just take land-based exercises and plop them in the water and call them aquatic therapy. Back in the 1990s and all the way through today, therapists from every profession, massage therapy, exercise physiology, athletic training, speech, have taken what were originally land-based ideas and permutated them so that they actually have become very much foreign to any land-based brother or component. So let's just cycle through some of the more popular techniques that have cropped up in the pool so that you have a basic understanding of what a technique is. Now, if you're interested in more information about these techniques, there are classes, videotapes, books, and there's a whole section in your manual on how to find these on each technique. Let's start with I Chi. I Chi was developed by a gentleman by the name of Jun Kuno from Japan. He came to the U.S., he attended a conference, he learned Watsu, which we'll talk about in a minute, and he felt very drawn to it, but he realized that if he took it back to the Japanese people, especially the elderly, that they probably would not embrace the close physical intimacy that came with Watsu. And so he decided to marry some of the concepts of Watsu with something that was more part of the culture, which is Tai Chi or different forms of martial arts. And so I Chi, flowing aquatic energy, is a kind of a marriage of the best of both things. And in I Chi, which is typically taught in a class format with the instructor on the deck, people move through forms or they move through patterns that are the same that you learn, much like you would in an exercise class, like an aerobics class. And the focus is on balance, range of motion, and breath. Next is aquatic PNF. And this is basically taking PNF patterns like you would do on land and putting them in the water. Now, we took those PNF patterns and put them in the water in a horizontal position and came up with the Bad Ragaz ring method. Bad Ragaz is just a place in Switzerland. Bad means spa, and they actually pronounce it bad. What they did is they took Margaret Knott's PNF patterns and said, well, what would happen if instead of the distal end being free and the proximal end being stable, you stabilized the distal end and had the body move as if it was on a powder board. So that the therapist is stabilizing a limb and the body of the patient is supported by a collar, sometimes a noodle, and the body is coming to and from that stable point and doing variations of PNF patterns. Now in America, we've kind of co-opted the term the Bad Ragaz ring method and tend to say, oh, anything where you're lying on your back and you have a collar on is the Bad Ragaz ring method, but that's not true. Typically, it's stabilization patterns and strengthening patterns done in spiral diagonal patterns. Well, what about Feldenkrais? Aquatic Feldenkrais or fluid moves is kind of the term that it's come to be known under. It's just taking Feldenkrais patterns and transmogrifying them so that instead of lying on a mat, you have your body pressed up against the wall of the pool. Next is the Hallowek concept, and this grew out of kind of a learn to swim phenomenon. James McMillan was working with some children in the Hallowek School for Crippled Girls, taught these girls how to swim, took them through a 10-point program. And originally it was kind of an adapted aquatics focus. But therapists saw it and realized that the ability to control rotation was a big part of what they were doing in therapy. And so James McMillan, developed kind of a part B to Hallowek that became more about therapy instead of about adapted aquatics. Swim stroke training and modification is just taking your traditional swim strokes and altering them for someone who has a reason that they can't do them, an inability to rotate, spinal cord injury. And there are cases in which swim stroke training is therapy. There are many cases that it's not, and you certainly have to have a reason to be teaching someone swimming as part of therapy. Task type training approach is a kind of a concept. It's not really a technique. It's the idea that instead of breaking something up into its component exercises, you just simulate the task. So you take a tennis racket into the pool and you play tennis, or you play basketball, or you lift a box, or you practice push and pull like you would at work. And so you're simulating a functional task, but you're doing it in the water with the support of the water and the feedback of the water and so on. Watsu. Again, Watsu stands for water shiatsu, and it's this amazing technique where the therapist cradles the patient in their arms, and through a series of movements that create drag, you stretch and position someone to be prepared for shiatsu massage. Now, in therapy, we tend to use it more for its positioning and its stretches than for massage.
So let's take a look at how these techniques look in the field. This video shot by Aqua Brazil does a really nice job of showing each of the movements from a bird's eye view, above the water, and from underneath so that clients, patients can follow the flow. In each movement, you'll see a slowness, a continuity, and a purposefulness of movement that emulates to some extent what you see in Tai Chi, but it's really the perfect marriage of Watsu, yogic breathing techniques, and Tai Chi. I Chi can be used as a precursor to a Watsu session or a cool down after exercise, or it can be the entire session. There are I Chi classes throughout the world where an instructor has an entire group that is following them through the forms. Many of the tenets of I Chi are based on the tenets of Tai Chi, some concepts such as make motions in a circular way, thus aiming for internal and external harmony. Another concept often seen in Tai Chi is relax both inside and outside to promote blood circulation, or move at an even speed, controlled by the mind, not the body. Drive out worldly thoughts from the mind and concentrate. These ideas are seen both in Tai Chi and in I Chi. Now let's take a look at Watsu. I Chi had its birth from, as we said before, Jun Kuno seeing I Chi and coveting many of the nuances of it. One of the things that the therapist here is doing that a lot of my students fail to do is taking time at the beginning of a session to assess the client's breath, to determine when they inhale and when they exhale. Physical therapists, my profession, tend to try and get to the meat of the matter. We try and rush in and perform some sort of billable move. Stillness, quiet, lack of motion, all these things seem to us to be failure, to be a lack of therapeutic intent. But just like in music, if you only have a note after a note after a note, that continuous stream of notes is cacophony. It's not music. It's only when you put in pauses and stillness and moments of reflection that it becomes music. And the same is true in a Watsu session. I find that sometimes students understand this better when I relate it to something very common in our profession, which is a manual muscle test. If you perform a manual muscle test on someone and you pounce on them in order to apply the force, you get a completely different reaction than if you ramp up to the intensity of the test and then ramp off. And the same is true in Watsu. If you take the time to assess where the patient is, are they settled down into the water? Are they breathing fully? Are they exhaling? Before you even put your hands on them, there's an amazing connection that the warm water, the buoyancy, the viscosity of the water, and the intimacy of holding someone cradled in your arms in order to perform flows and stretches, that it gives you something out of them that is very difficult to achieve in any other environment. Now, Emily is doing a wonderful job of demonstrating some of the basic postures, flows, and positions of Watsu. What I want to ask you to do is think as a therapist and think about these positions as being the precursor to function. This double kneaded chest, this accordion position, can be used for so many things. As you elevate the head up out of the water, you can take what is predominantly a passive technique, which is Watsu, and you can capitalize on it and attach to it function. So a rocking motion to a sitting position, which was just seen, can be capitalized on to achieve a supine to sit transfer. Or a near leg rotation, such as this, can be used to initiate a roll. So, although Watsu at its genesis is a passive technique, as a physical therapist myself, I can't help but be delighted by the possibilities of using these flows to initiate function. So, a double kneaded chest with the feet against the wall can enable me to spring load somebody so that they can push off as a precursor to gait. Or a posture such as this half sit up position that Emily has her patient in can be used as a transfer or as a roll or as a diagonal sit up. The possibilities are really phenomenal, and I would like to encourage you to see Watsu not only for the beauty of pain relief, tone reduction, range of motion, all of the classic things, but to also see what you can attach to it to create a functional task. So let's move across the pond and take a peek at both the Hallowit concept and the Badragaz ring method. These are both very European in origin. Certainly, Badragaz, Switzerland is well known as the home to many of the techniques that are seen in aquatic therapy clinics across the globe. The Badragaz ring method, or Badragaz as it's often referred to, is a series of spiral diagonal movement patterns, and these patterns are broken up into a lower extremity series, a trunk series, and an upper extremity series. Flotation elements are used pretty liberally in order to streamline the patient on the surface of the pool. You see here examples of what the actual rings might look like. In the United States, we often substitute a hip belt or buoyancy cuff, but the rings will streamline the body on the surface of the pool to enable this really powerful coupling of stabilization and mobilization. And one of the points I'd like to draw your attention to is how shallow the provider is, around T11. And the rationale behind that is if the therapist themselves is not grounded, if he is not grounded, there is no way for him to perform the stabilization that he requires himself in order to provide a stable base off which the client can move. Performing these techniques takes a lot of training. You have to learn how to position the patient for the beginning of the pattern, how to determine which joints are going to be involved, the component parts, exactly where to hold the patient in order to get that correct movement. how to use verbal commands to get the exact pattern that you want, and how to facilitate that pattern or inhibit another pattern. You have to know what the proper finishing position is so that you're ready to institute the next phase, and you have to be able to progress the patient. And frankly, in the United States, our managed care system has made it difficult to work with clients for a prolonged period of time. And so I think we've lost out on some of the more powerful bits of the technique. Okay, let's move on to Hallowick. In this example, you see really rather advanced version of transversal rotational control. The fundamental ability to rotate from supine to sit, from prone to sit, or to stand. In this example, you see the therapist cueing a lot of changes in positions of limbs, which of course create rotational elements that have to be corrected. In this clip, you see the client learning to control the ability to rotate longitudinally. You take someone, you put them in the water. If they are unable to rotate in these two planes, and really a combination, which is what this clip shows, a combination of rotation in those two planes, the fundamentals of safety in the water have not been met. So from a learn to swim or adaptive aquatic standpoint, rotational control is key. Now, therapists look at this and they say, well, so much of what we do is about, let's say, encouraging rotation or facilitating a movement of one limb while you stabilize another. These are all things now taught through the Hallowick concept. Okay, let's move on. Let's take a look at sort of a fun technique. It's called fabricaping. A woman by the name of Rosemary Herlong wondered what would happen if you took a piece of fabric, a sheer piece of fabric that you could get at any clothing store or fabric store, cut a hole in the middle of it, and made for yourself a cape, something like a bullfighter's cape, where you're taking it into the water to serve as both a visual cue and a tactile cue. Now, this fabric does not create nearly the drag that a bath blanket or even a towel or a towel for two would, but it does create a little bit of increase in awareness of where your limbs are in space. More importantly, it creates a sense of flow, rhythm, and in a way, it looks to me like the rhythmic gymnast. And I find that patients that use a cape like this are more attentive to a crossing of midline or finishing their movements or doing things with a flourish. And it's fun to see people enjoying movement. Let's take a look at what Pilates might look like in the pool. There's a million versions of it. This is just one example, but one of my favorite things to do when I take someone into the pool is to get a closed chain out of the upper extremities. So a modified plantargrade position, a modified prone position. In this clip, Kim has positioned her client over by the stairs, found a depth that is a challenging depth without being overwhelming, and is working on everything from scapular stabilization, serratus punch, a closed chain weight bearing, to the arm and leg raise that you're used to doing from a quadruped position. Now notice that Kim is stabilizing under one leg and underneath the abdomen to make sure that there is no excessive lumbar lordosis happening. The nice thing about working in the water is that you can find the sweet spot of effort and ease. Now you'll see what happens when Kim asked her client to move up, really just 6, 7, 8 inches onto the next step up. It completely changed the biomechanics of the exercise that she's doing and makes it look ugly. And that's what happens when you challenge someone beyond their abilities. In the pool, you can nuance depth and level of immersion, which means that you can nuance effort. Now, one of my favorite things to do is to execute a flip turn. Typically, I'll have the patient put their feet on the ground so that they have a little bit of a grounding point, but just flipping back and forth between a modified prone position and this, if you will, dip position provides a nice rotational element, works on range of motion, the whole gamut. Now, from this position, again, a nice Pilates overlay, you can perform spinal stabilization, a core strengthening task while you're asking your scapula to stabilize. Now, if you notice her fingers are going out to the side on this step, I would probably cue her to wrap her fingers over the edge so that she's in a little bit more of a neutral shoulder position. But really nice to see a closed chain strengthening task that the patient can actually perform. So let's progress it. If your client can execute that with no trouble on a stable base, examine what happens when you create an unsteady or unstable base upon which to weight bear. So Kim has taken two noodles. Neither noodle is very buoyant, and so she's trying to create enough buoyancy for the patient to have a modified weight bearing, but it's very difficult to control two noodles, and the patient is unable to execute. All right, let's look at what yoga might look like in the pool. Again, many variations from the very difficult to the more easy concept. One of the things that I really appreciate about this yoga clip is how the instructor makes a point of not just cruising through the positions. Oftentimes in the pool, we create momentum, and that momentum carries us through. One of the beautiful things about doing yoga in the pool is that when you do a position like warrior or you do a position like a modified plank, you can not only reach that position, but you can hold that position. And from that hold, you can work on breath and gaining the nuanced movements that if you were underneath gravity's sway, you would be working too hard at just maintaining that posture to work on those nuances. In the pool, I love to see a technique that encourages you to just kind of milk that moment for all it's worth. Doesn't happen a lot. A lot of times we just rush through every transition and move on to the next. I like to see this. Now, although this yoga is being taught in a group format, it's certainly possible to put your hands on a patient and get a little bit more of hands-on therapy application. Okay, let's take a look at what manual therapy, stretching, myofascial release, any sort of hands-on manual technique might look like in the pool. I really like this clip, and the reason that I do is although it may look a little bit overwhelming at first, what Kiki has done here is capitalize on this patient's self-selected position. This patient wants to be able to lie prone and kick on the surface of the pool and had asked Kiki to hold his legs up so that he could try to do so. And what she did is she capitalized on this golden opportunity in order to gain what she needed in order for it to be possible for him to rotate and to get quite an adductor stretch. Now, here's another example of sort of an easier way to work on the tightness of the adductor and rotator muscles of the hip. Now you see Kiki standing at the knees, and what she's doing is applying an external force to try and separate the knees enough that she can place her trunk in between the knees. She can even turn her body sideways so that she can kind of slide in on the angle. And then once the knees are on either side of her trunk, she can let go with her hands, and her trunk provides the sustained stretch. And then she can take her hands, reach underneath the pelvis, and provide a gentle lift up towards the ceiling, which streamlines the client and provides both a anterior hip stretch of the flexors, as well as this concentrated, prolonged adductor stretch. In this next clip, it's really possible to see how much ease and lack of effort it can take to provide a really profoundly powerful stretch. And one of my favorite things is how easy it is to couple things together, to do a latissimus stretch at the same time that you're mobilizing the ribs or performing an anterior hip flexor stretch. These types of coupled movements are very sophisticated, and really it would be almost impossible to execute this type of flow of coupled patterns outside the environment that buoyancy provides in the pool. All right, let's move in a different direction. Take a peek at what sensory integration in the water might look like, how it might look to transform your pool into a sensory integration chamber. Now, obviously, you are looking at multiple senses that you're attempting to stimulate or to inhibit. And rotational elements, rolling, springing, flipping, jumping, hopping, are very easy to perform in the water. You can also couple the rotational elements with the tactile stimulation that you get from something as simple as a bath blanket. You can take a bath blanket, and the wetness of the water provides a cling effect, which creates more sensory information. And of course, at the end here, we're just providing some additional rotation in order to get out of the bath blanket. Kids love this one. Okay, this is something we call the strongman competition, and what we've done is again used the natural elements in the pool. We've used the ladder, we often will use the steps, and taken some bath blankets, wet them, and use them to create a sensory effect. So we can place a wet bath blanket over the shoulders to get a heaviness, almost like a weighted vest. And this bath blanket can be positioned so that it's over the entire trunk and clinging. It can be positioned over the head so that you have some weight on top of the head. It can cover the eyes so that you lose visual information. It can be positioned really in almost any place that you choose. And obviously, every time that the patient attempts to get out of the water, what's happening? They're getting not only the weight of gravity, but the excessive weight of the water absorbed into each of the bath blankets. It becomes unbelievably heavy. So I'd like to wrap up this section on specialty techniques with some ideas or tricks for altering the complexity and the difficulty of each of the tasks. No matter what technique you perform, one of the easiest ways to alter how difficult it is to simply alter the profile of the limb or body part moving. You can increase the frontal surface area simply by asking your patient to bias their limb position or to add an external resistance device like a paddle or a bell. This enlarges the frontal surface area, which increases the drag, which of course increases the effort. Another simple way to change how difficult it is to move through the water is to simply ask someone to lengthen their lever. When somebody is fatiguing or tired, they automatically shore up or decrease the lever of the part moving. When you want something to be more difficult, you ask them to conscientiously lengthen the lever, stiffen the joints, don't allow the knee to bend as much, don't allow the elbow to be soft during the movement, and certainly on top of it, you can make a conscientious effort to have a very long lever by adding a paddle or a bell on the end of your limb. A third way to alter how difficult something is to simply capitalize on speed or velocity. As we've already discussed many times, your most powerful tool, the thing that gives you the biggest bang for your buck, is how rapidly you're moving. Now, when you move more rapidly on land, this does not necessarily translate to more difficulty. In fact, it may translate to less difficulty because you're allowing momentum to do the work for you. But every time that you ask your patient to move faster when they're under the water, a doubling in speed produces a nearly quadruple effect. You get almost 4 times the amount of resistance every time you double your pace. How about capitalizing on the patient's slipstream in the pool? When you position yourself in front of the patient, you are drawing them along and making it much easier for them to move. When you position yourself immediately behind in their bow wake, you make it more difficult. You can alter how easy it is to move simply by changing your position. Many times I'll hear therapists complain because they don't have a treadmill, an underwater treadmill, or a current or jets. You can create balance and strengthening challenges by creating a situation where you create your own current and then ask your patient to overcome it. You can also use the blowback effect that you get when you're near the edge of a container. This is called rebound. You can position your patient so that they are near the wall or near the edge of the corner of the pool, and you will get varying degrees of instability. And depending on whether you want the patient to be uh, unstable, or you want them to have the best stability possible, you may choose to position them in the corner to get a lot of chaos, or out in the middle of the pool with very little rebound effect. Either way, you're in control of what is happening to their environment, and thus you can alter the complexity or difficulty of the task with simple positioning changes. Two of my favorite ways of adding complexity to a task are using an elevator concept and a clock concept. The elevator concept can be used for stretching, where you're asking people to take the stretch to the first floor and back to the ground floor, and then past the first floor to the second floor, and so on. Or it can be used, like is being demonstrated in this clip, to ask the patient to stop at each floor in a scapular or spinal stabilization task. So you have a buoyant object, you're pressing it down in the water, and instead of just a gross motor task of pushing it down and lifting it back up, you're being asked to nuance the movement and stop at various floors. You're mirroring what the therapist is doing, or you're being asked to have the proprioceptive awareness yourself to find out what the first floor, and the second floor, and the third floor, and so on feels like. Now, one of my favorite things to do when working in the water is to couple the concept of the elevator and the clock. You take a patient that's used to working in one dimension and you challenge them in the X, Y, and Z axis all at once. So you've taught them the elevator concept, and now you introduce the idea that you're standing in the middle of a clock, your arms are the hands of the clock, and you introduce a 12 o'clock, a 2 o'clock, a 10 o'clock, and you couple that with the immersion. So you might cue somebody to either just mirror what you're doing or ask them to move to 9 o'clock and down to 2 o'clock, or down to the second floor, or over to 2 o'clock and all the way down to the basement floor. So you're getting nuances of contractions of the rectus, of the obliques, and certainly of every other spinal stabilization uh, muscle group that there is. Okay, you should recognize this, the four walls concept coupled with the pyramid concept. You do a task facing one wall, you do it a certain number of times, then you turn to another wall, you turn to another wall, you turn to another wall, and then you do it a reduced number of times, and so on and so on. Now, people get the idea of doing it for an aerobic task or circuit training. The piece that I want to draw your attention to is the fact that you can use the four walls concept even if your patient can't participate. So if you're holding them in your arms and doing a stretch, take the opportunity to turn and face another wall so they get more information, more visual information, more vestibular information into their system. Okay, the next two ideas for altering the complexity or difficulty of a task can be demonstrated together. What we're doing here is called build a move. So you teach your patients a simple move like a side to side step, and you work with them until they get that movement down, and that becomes move number one. So you stop at that point, you tell them we're going to move on to a second move, and you teach them a new move. And let's say that new move is a squat. You perform that move until they get exactly what it is that you're asking from a motor perspective. Then you stop and you say, okay, what was the first move that we did? And instead of providing it for them so that they can parrot the move back to you, you ask them and ask them to initiate the movement. Okay, so we're back to move number one. We're doing move number one for whatever period of time it takes to get the idea that they have it. Then you ask them what was move number two and ask them to lead. Okay, so now we're doing move number two. Well, what's the next step in this parade? After you get a sense that everybody's on the same page here, you're going to say, okay, I'm going to teach you another move. It's going to be a third move, and this move is going to be, let's say, a knee to chest and slap with the opposite hand. And you teach that movement, and then you're going to take them back to the first movement, the second movement, the third movement. And if you want to add a challenge, you can certainly change the position, the relative positions of these movements. Now, I also want to draw your attention to the fact that this is the perfect opportunity to tap into a cognitive overlay. A cognitive overlay is really simple to understand when you recall that you're balance training someone, you're walking with them, you're gait training them, you're walking down the hall, you ask them how their daughter's doing, and the person stops in their tracks. As they process your request for information, their motor planning ceases. And And anytime that you ask somebody to execute, especially a higher cortical reasoning or processing uh, element, the motor task is going to be more difficult to execute. So you can do something as simple as have a conversation with them. You can ask them to do namings, how many fruit trees are there in the world. You can ask them to sing a song, or you can do like we're doing here, where you're asking them to recall instead of parrot, for them to come up with the uh, task number one, task number two, task number three, and so on. So let's talk about the unpredictability factor. Earlier in this series, we talked about calling out rapid fire, unpredictable commands as a way of making things harder. But you can simply provide an unpredictable environment by creating a current or turbulence, or by altering their depth, so that it is difficult for them to maintain a certain level of effort or a certain position, because the environment around them is what's changing. Okay, this is what I call the Food Network Challenge. Whenever I travel, I stay at the hotel, and I was pleased to find out there was a network called the Food Network, and has a show called Chopped on it. And I really enjoyed it because there's three chefs that are brought in, and these three chefs are given three materials, much like Kim is issuing the ingredients here. And the three ingredients have nothing to do with each other. They give them lavender, grape jelly, and paprika. And basically, they ask these chefs to create something masterful out of these three unusual ingredients. And one of my favorite things to do with students that are therapists is asking them to use three pieces of equipment that they wouldn't normally couple together, and to achieve a certain task out of it. So let's say I've asked them to work on lower extremity balance. So I've issued a polyspot, a jump rope, and a noodle, and asked Kim to create a task out of these items. Now, it may not be as applicable for the patient themselves, but it certainly stretches your brain as a therapist. I really enjoy teaching, but I enjoy even more when my patient, client, student, whoever can teach back. Because if you have heard something or seen something, you kind of understand it. When you execute it yourself, when you perform it yourself, you understand it a little bit more. But if you are able to teach that back to me, I know that you own it. So, one of the techniques that I like to use to alter how difficult something is to teach a task to a patient and then ask them to teach the teacher, to teach it back to me, to see if they understand what it is they just saw. Because it's one thing to parrot a movement, to do the exact same movement, and it's another thing to perform it and teach it. And then I will often throw in an element of an incorrect execution, and I ask them, what is it that I'm doing wrong? Okay, the last two ideas that I can suggest for making any of these techniques harder or easier is to either increase the amount of sensory information or to decrease it. So in this clip, Kim is providing a very distracting auditory input that is not in rhythm with the marching that her patient is doing. She's asking him to ignore this annoying clap and not to pace with it. Auditory information is just one way to create a sensory overload. You can also alter the depth that the patient is in. They're going to get more weight bearing through their joint receptors the shallower that they are. They're going to get less proprioceptive input through their Golgi tendon organs and muscle spindles because they're not going to have the drag of the water moving. It's just another way to change how much sensory information your patient is getting. Of course, one of the simplest ideas is to alter the patient's visual information and make it so that they have their eyes closed, or that there's a darker room, or that they're not looking at their feet while they're trying to execute a motor task. This certainly decreases the amount of information from a sensory perspective and requires the patient to rely more on their proprioceptive feedback loops. The savvy therapist can take any therapy pool. They can take the completely suboptimum pool. It has the wrong depths, it's not deep enough water, it's a cold water temperature, the lighting is weird, there's no equipment in the closet, there's people coming in and out that are distracting your patients. The savvy therapist can take these 12 elements and create a therapeutic moment in almost any atmosphere. They can take it and create a challenge, or they can make it easier for a patient so that every moment of that 30, 45-minute, or 60-minute appointment is used to progress, because progression is at the heart of therapy. Take a moment, pull out the lab section of your manual, and laminate that puppy. Take it poolside, and every time you get into the pool, challenge yourself. Ask yourself to do something new.
Some closing thoughts. Number one, the therapy pool is a place. It's a piece of equipment. It is not a discipline. We use the term aquatic therapist because it's convenient, but you're still, whatever your profession is. If you're a massage therapist, you're a massage therapist that works in the water. If you're an athletic trainer, you're an athletic trainer that gets wet. If you're a PT that works in the pool, you're an aquatic PT. The pool is just another piece of equipment that allows you to do your profession. We do not all become the same being, the same profession once we hit the water's edge. You are still whatever your profession is, and your scope of practice remains the same. Number two, aquatic therapy is a specialized intervention performed by generalists. In other words, you have to have a unique body of knowledge to do aquatic therapy. And you typically see every kind of patient population under the sun. You see children and adults and pregnant women and old people and, the whole gamut you see. And so you have to have a little bit of knowledge about everything. You need to be a generalist. But if you just take someone who doesn't understand water and you put them in the pool, you're doing them a disservice and you're doing the patient a disservice, because it's going to turn out to be something similar to aquatic fitness or exercise, which is not the beauty of aquatic therapy. Third, what makes aquatic therapy can be invisible to the eye. So if I'm watching somebody exercising in the pool and they're doing this pattern, and I look at that and I say, I could have come up with that. That's just an exercise. Why is that therapy? What makes it therapy is the invisible part to the outsider. It's the understanding of healing rates and how much force should be applied, and all of the pieces that went into deciding to put them into the pool to begin with. Oftentimes it will look like an exercise, but it's therapy because you evaluated the patient and you came up with a list of impairments, functional limitations, and disabilities, and you applied the right treatment, and that's what makes it therapy. Okay, so we're coming to the end, and you might be asking yourself, where do I find more information on aquatic therapy? Where can I find research? Where can I hook up with other therapists that are interested? Where can I find a student who wants to come and do an affiliation? Or if you're a student, where can I find a facility that will take me and train me? We have the answer to that question. The Aquatic Resources Network is our informational hub. So we think of ourselves as the hub of a wheel, and all the spokes are the different professions, because until we started doing this back in 1996, nobody that worked in the water was talking to each other. So we connect the PT, the OT, the speech therapist, the exercise physiologist, the MD, the nurse, the massage therapist, the therapeutic recreation specialist, all these people that use aquatics and have a common love. And we have created what we call our Aquatic Therapy Command Center. So if you go to aquaticnet.com, then you have over 8,000 pages of information that prevents you from having to recreate the wheel that somebody else has already done. Okay, lastly, I just wanted to say thank you for attending the Aquatic Therapy Boot Camp. It's very similar to what we would have on our Minneapolis-based campus. We will see you in Minneapolis. Thank you.